So we have presented our real-world data for bispecifics in the UK. We had a cohort of 138 Glofitamab patients and 38 epcoritamab patients. And essentially, we saw that our cohort was a high-risk cohort, median of 3 prior lines of treatment. So most of our patients were having this treatment 4th line and beyond. And yet, despite this high-risk group, we did see a complete metabolic response rate of about 27%. And we saw that this was durable at 12 months in more than 3/4 of patients. So I think that we were pleased with the response rates in such a high-risk group. I also think it was quite interesting when we looked at the patients who had had prior CAR T. So 60% of our cohort had had prior CAR T. And as we maybe would expect, the patients who had been failed by CAR T did have a lower response rate. So our CMR rate for that group was 24% compared to 32% if patients hadn't had prior CAR T. And then the other thing that we found quite interesting is that we found that our patients responded less well if they had had prior bendamustine, particularly if it was within 6 months of the treatment with bispecific. So I think that all of these things we need to continue to look at, so it will help us with deciding about treatment sequencing. And the other data obviously is toxicity data, and our toxicity data was very similar to what we've seen in the pivotal studies. So about 1/3 of patients had cytokine release syndrome, but it was mainly low grade, with 16% having grade 2 and just 5% grade 3. And we saw ICANS quite infrequently of about 4 to 5%. So I'm pleased with our UK real-world cohort. It's a large cohort, and we're going to continue to collect these data so that it can guide us about use of bispecific antibodies, and hopefully that CMR rate will improve when we're seeing it used more and more in a 3rd line setting where it has license.